Today we're talking about the value of a UNLV med school, and I think it's going to be a very rich conversation, and I'm excited to see what comes out of it. So thank you all for your support. And now we're going to have, if you look on the back of your agenda, everybody's bios are on the back, so I will not be reading them to you, but we're going to hear from Dr. Rob Lang, and it's a short history of the UNLV Medical School, which, you know, it should be short.
Does this clicker work?
Yep.
Okay. Can you hear me? Yes, this is on. I'm always in these lights up here. It's blinding. So Lincy Institute is a policy shop. Our purpose is to develop knowledge as a platform for policy making. Today's conference follows up on one we did almost a year ago, where we commissioned a report to look at the economic value to the region of a med school, an allopathic med school in Las Vegas. Today is on valuing a med school in the multiple forms. That includes, of course, continuing the theme of economic development. We commissioned work on federal aid, how it anchors graduate medical education, and how it would lift UNLV to Carnegie research very high status, which is a priority. So yeah, how can you give a history of something, you know, that doesn't exist? Well, this is just a brief review of the background information that Brookings and Lincy together have developed in support of an allopathic medical school in Las Vegas, starting with the State Economic Development Plan. And one of the data points that jumped right out in the State Economic Development Plan from the get-go was that Las Vegas was doing only just under, really, 2/3 of its predicted medicine. I'll go into a little more detail in that at the end of my talk because I show where we are today. But in 2011, we were doing slightly less than 2/3, and we put a recommendation, and this is me and Mark Muro, the principal authors of this report, and Ophelia Young from SRI. We put a recommendation that the state should support a medical school, an allopathic medical school in Las Vegas. And it was part of what we called the M&M strategy, which was we were asked a specific question by the governor and his staff. They said, so we have lost several percentage points of gross domestic state product in both Reno and in Las Vegas. What is the fastest path to the restoration of that GDP? Now, in the north, tourism was declining even in the face of a boom in the previous decade. So we said clearly the restoration of tourism is impossible in Reno. And our recommendation was for green manufacturing was the strongest case for growth because of the spillover from the Bay Area. And in the case of Las Vegas, we said we thought that the Las Vegas tourism economy was suffering only a cyclical downturn and that it was in actually very competitive shape and that it would recover and it would expand off that base, but that the fastest path to diversification was just doing the medicine that the region predictably should do. So if you, in fact, we lost several percentage of GDP, mostly from construction. Construction at one point was about 12% of the regional economy. It's down to 5%. The share of medicine missing approximated all of construction. So if you could just get medicine to the level of what a 2 million person plus region would have, we should be fine. In 2013, Brookings did another analysis on health services. And of the top 100 metros, and by the way, we're 31st ranked in terms of size, of those top 100 metros, we had by far the smallest share of workforce in healthcare. That makes sense because all the previous findings confirm that. In 2013, Lincy commissioned a study by Trip Umbaugh. They're here today. Paul Umbaugh is somewhere in the audience. Thank you very much. And we looked at the economic impact. This was just for Las Vegas, $1.1 billion per year and 8,000 jobs, but there was a statewide figure that was larger by about 50%. The Lincy Institute this year commissioned a piece, and you'll see it, from John Hudak from Brookings that looks at federal funding. Now, one of the other findings that we have is that this state is dead last in formula-based aid. And that means not defense spending, which we do well in because we have clear air and great climate and lots of space to fly around. We do well in retirees, drawing in resources from the federal government because the federal government follows a retiree wherever they go and pays out their Social Security and their Medicare. Our problem is in the area of investments in education, health care for non-elderly, transportation, all that, we're last. So one of our questions was, what is it costing us to not have a medical school in Southern Nevada. One of the habits of the state, too, is not to access Washington through the biggest region, which is us at 2 million plus, but to access it from the north. And so one of the deficiencies in doing that is that when you have a couple of million people, you have the health care demands for that programmatic or NIH money, from the National Institutes of Health. So if you forego that, how much is missing per year? And John Hudak will answer that. Also, there is a recently published Brookings Institution Mountain Monitor, and there's also the Metro Monitor, which it's derived from. And our data is current, as of last week, to the second quarter of 2014. So it's as recent a data as you can have. And what it shows, there's something called a location quotient that I mentioned previously, that when I said that we were doing less than 2/3 of our healthcare, I was referring specifically to a location quotient which is still 0.64. I mean, you're not at 1.0, you're not at parity. But this is what's interesting. During both the recession and the recovery, health service jobs grew. You're in deficit when everything else in this region was hemorrhaging, and we were adding health jobs. Now, we've added enough to just keep up, because we were at 0.642 before and we're at 0.64. But we're not adding them fast enough to gain ground and to add to GDP. So what is a location quotient, just to make sure you understand? It's the metro area share of total jobs in an industry divided by comparable share nationwide. So values greater than 1 means that you're exporting, that it's a specialty. Values less than 1 means you have to import it. Keep that in mind. So this is where we are in 2014. We export leisure and hospitality. It is by far the largest export of the region and the state. In fact, it's the principal export, that's service export from the state of Nevada. There's some material export and mining. There's some gaming equipment. This counts under sporting goods, by the way. But for most of the state's wealth, most of the wealth we generate by exporting to other regions of the United States, and more importantly, to the rest of the world, it's actually leisure and hospitality. Construction has shrunk down to about parity. We're still a little high because we're still a Sun Belt region and we still have a little more growth. And then you look at trade and business services, and they're right at par. And then you see health and education, so-called eds and meds. Now, in the rest of the country, big metropolitan areas, which I'll show you how big we are in a second, really push eds and meds. That's been their great success, because the way it works in the United States is that the top 50 US metros are booming with education services and medicine. And they're exporting it to the rest of the US and to other parts of the globe. So if you think of the big Texas cities, if you think of New York and Chicago and Los Angeles. Now, where is Los Angeles exporting health services? To us, of course. You see, what we do is we invite them up for, say, March Madness. And they spend a fortune. And then we return the favor by sending the workers back to Los Angeles for the most expensive consumer service you can purchase. And education is an expensive consumer service as well. And when we don't have those consumer services here, we don't get the federal money in eds and meds, because the federal government puts a lot of money into education and health. And so what we're doing is we're throwing that share of the regional economy away, not just in that it's underperforming in terms of GDP. We're throwing away that share of the regional economy as well, that it's one of the areas, especially health, supported by the federal government. And by not putting in place a substantial Carnegie Research Very High University, and by not putting in place a medical school in the largest city in the United States by far without a MD granting medical school, we are in essence foregoing the predicted share of federal money that would be invested here. So most regions above 2 million have this quality of their economy because of scale. Almost all of them have a Carnegie Research Very High, and all of them have an allopathic medical school. That includes Orlando, which you'll hear about later today. Orlando has been doing a wonderful job of taking kiddie parks and turning them into a globally expansive empire. And it's been doing it in everything from the simulators that you sit in, in the Despicable Me ride at Universal, which came from their work at NASA, which is innovated at University of Central Florida, where we have the dean of the medical school here today, and by putting a good medical school in place, and by having different numbers than we do, which is to say, when you look at Orlando, they're almost 3 if you go on the website for Brookings and you pull up the metro individual breakouts on all these regional economies, without going into detail, I don't have the time, I could compare Orlando to Las Vegas. The basic comparison is this. We have the same tourist sector by way of export. The difference is they're not at 1.0 in meds and eds, they're closing on it. So Orlando is filling in meds and eds in a way that we're not. We're still in deep deficit. We're just over 50% in education. We're 2/3 in medicine. And they're in the 80s. And they're heading for the 90s. And that's good for them because what that does is it means that Orlando's more resilient than we are. They've diversified their economy not by foregoing tourism where they have the world's competitive advantage in kiddie parks and translating kiddie parks into digital media and selling that around the world. All the games derived from those park rides now are one of the exports. What they've done instead is they've just said, for a region over 2 million, this is the share of medicine and education, and they have a Carnegie Research very high school in the University of Central Florida, and they have a med school. This is the share of that economy that our scale, that our requisite scale would support. So how big are we? We're just over 2 million in the region, 31st ranked. Our combined statistical area is 2 million plus, it's 2,273. And finally, this is the last slide, just to show you, people don't realize how big Las Vegas is. It's in a family of sort of similar size combined statistical areas that run from about 2 to 2.5 million, that are most of the big cities that you think of in the United States. And the difference is that if you look at places like Cincinnati, Columbus, Kansas City, where we have the former dean from, all of them have these qualities that I mentioned. In other words, all of them have eds and meds at scale for a region that you would predict. And our easiest path is this, that in a sense, we can just collect this by making investments that end up being public-private partnerships in these sectors because they induce both the federal aid, they create the economy, they satisfy the demand that's indigenous within the region because the first thing large regions should do is take care of the most expensive consumer services that exist as regional demand within the metropolitan area. You don't have to reinvent something. You don't have to create some crazy new technology. If you just educated everybody seeking that education services in rough proportion to population and you provide medical services for every person in a region that's in demand of those medical services that doesn't have some kind of crazy specialty need that has to go to Los Angeles or Texas or New York, then you would have a much larger regional economy. And you would have a GDP that far exceeds the previous peak GDP in 2007. And yes, we are not yet at our previous high GDP. We have passed it, that GDP, in tourism. But we have not recovered the loss in construction. And the surest path to that is eds and meds. Thank you.
What am I doing? Oh, okay. Am I in your way?
Well, that was Dr. Lang with a mouthful. It sets a very good stage for what we will talk about today. And now we have Dr. Barbara Atkinson, the planning dean for the UNLV Med School. Thank you.
Thank you. And thank you, everybody, for coming and hearing about what we're doing and what the vision is for our school. I won't spend a lot of time on what the need for a school is. You just heard a fairly dramatic presentation of that. But I will say that in Kansas City, since it was mentioned that that's where I was before, we have 2 public medical schools. The University of Kansas turning out 175 medical students a year for 100 years. We have the University of Missouri, Kansas City with 175 medical students in a class. And we have a very strong osteopathic school as well with over 200 students in a class. So just to compare a region that's very similar to this one. In my mind, the real issue is there are not enough doctors here, there are not enough specialists here, and there's not that economic benefit here. That leads to long wait times for appointments, and it leads to people having to leave for specialized services. And that's really all I'm going to say about the need for the school. What the vision is one of the reasons that brought me here. The vision is really for an academic health center, which I'm going to talk about more in a minute, but it really is first and foremost to educate first 60 students a year in a class, increase that to 120 as soon as we have a new medical education building built, and build that building so it can hold 180 students in a class ultimately, because I think that's a reasonable number for this population. We'll be recruiting faculty starting this summer, a few actually this year who are the major education people, but we'll be recruiting the faculty in order to be planning the curriculum and to be moving ahead. So we'll have 120 faculty certainly by 10 years, but a lot sooner than that I think we'll have more. The plan is to partner with the hospitals who are here, not to own our own hospital, but to partner with hospitals and other agencies and outpatient facilities here. And UMC and the VA and Sunrise, the St. Rose, Sienna, and some other hospitals look like they're going to be the ones who are our major partners. And we want to build research programs as well. So a full-service academic health center. We want to have the most innovative education program we can plan. So we've been talking to people over the summer and thinking about what doctors who are going to be practicing for the next 50 years, I hope, will need to know and how they need to think and what we need to do to teach them to do that job well. So the first thing that we've determined is that we're going to have a problem-based curriculum. And that's a curriculum that's very exciting to teach. It's very teacher-intensive, faculty-intensive, but it's where you start out with a problem like a patient comes in with a cough, something very simple. Then the students have to work out in small groups of 8 or so, without the faculty member telling them how to do it or lecturing in any way. They have to figure out what causes a cough, how it works, what's the neural connection to the lungs, what are the cilia, what's the histology, what are the organisms there. And then they move on as they work the problem out for about a week, thinking about then what things can cause a cough. Certainly things in the lung, but heart failure can cause a cough and so on. So they come up with their differential diagnosis, and then they have to go through the pathology of it all. And the nice thing about this kind of education is you can weave in the social things. It could turn out to be TB and it's spread to the community from a person who refuses to take their pills. So you can weave a variety of things all into one problem. In a curriculum like that, the most important thing is being able to learn how to get into the literature and find out what the literature says. And so that'll be an extremely important piece of this whole thing. Looking at how we set up the library facilities and looking at how we do that. We've decided pretty much, and I think it's pretty for sure, that we'll have virtual anatomy. So we'll do anatomy instead of with a gross anatomy that's typical. We'll do it with MRIs and CT scans and a variety of ways like that. We'll do virtual histology, which is all digitized images. So as high-tech as we can make our curriculum, but we want to concentrate ultimately on the actual communication of the student with the patient and then the doctor with the patient, and classic history and physicals as well. So all that as we work as part of an academic health center. So just to remind everybody about what an academic health center is, I see it as the School of Medicine and the other health profession schools together, working together as teams, centering the whole healthcare market. Everything that goes from UMC to other hospitals, to partner other schools, because I think we can be very good partners with Roseman and Touro, and we are already working very closely with UNSUM from Reno. We all are in this together, and we all need to think about what'll better the health care for the whole state. Public health is important. Research institutes, I'm going to talk about the Ruvo Institute being one that's very important. But then the physicians in this city as well. And I found that the physicians are interested in this school because they're having a very hard time recruiting doctors to the state, and especially specialists. So the Academic Health Center, we're thinking about these as the primary programs to build as both research and clinical programs, and then therefore the educational programs follow from that. These are the classic programs that in many communities have worked very well to make hospitals financially secure. I see orthopedics as one of the ones that does that, but all of them do. I see mental health and addiction being particularly one that never makes money in any situation, but is extraordinarily important in this city. So it's one that clearly has to be addressed. And neuroscience, I'll just point out the research element of that we may add. Working with the Ruvo Institute, the Ruvo Center for Brain Health, they do 3 neurologic diseases, and they do them extremely well: Alzheimer's, Parkinson's, and multiple sclerosis. But if you look at all of neuroscience, there's more than that. There's ALS, there's epilepsy. Stroke is actually the biggest neurologic disease. Headache, a variety of other things that we can work on clinically. But most importantly, they do the phase 3 and 4 clinical trials. We can do all the basic research on the patient populations that they have in their 3 specialties, and we can even add, perhaps at some point, phase 1 and 2 trials into all that. So we can expand their capabilities, and they can provide a patient pool for our research activities that could be extraordinarily important. So that's how I see working with all of these things, finding pockets of excellence in this community. And I have to say, I found an incredible number of pockets of excellence. The pediatric cardiology at Sunrise is incredible in doing research and doing everything that needs to happen. At UMC, there are wonderful programs, and we can build on those. We can build some of the programs that don't exist, like a liver transplant program at UMC, a bone marrow transplant program. Right now, people have to leave Las Vegas to get either one of those. The liver transplant surgeons at UMC do harvesting of livers and send them out of Las Vegas. They do kidney transplants and other things, but it shouldn't happen. It needs to happen here. So the guiding principles, we've spent a lot of time thinking about what kind of students we want to take and what we want to have happen with them. But first of all, we want to select students who we think will stay in Las Vegas to practice. I think that's something that's been difficult here and is clearly our goal. So that may mean that they come from this region. It may mean that they have family ties in the region. It may be that they're local in surrounding states. But anyway, we will think about what causes people to want to stay. One of the things is generally older students who have families and ties to the community. And a diverse student body is more apt to stay as well, just because they have very tight ties to family often. We do need a diverse student body, and that's going to be a main piece that we actually work on. Our accrediting agency looks at diversity and says you define a population for your school, and ours will be Las Vegas or Southern Nevada. You look at the demographics of that population, and they want to see the student body mirror that. They want to see the faculty and staff mirror that. Now, if you think about the demographics of this population, we have a long ways to go to get a student body that will be even close to that. But we are going to work very hard to do it with pipeline programs, with other colleges, Nevada State College, other UNLV, our own population of students is actually very diverse. So that's going to be important. Then we provide an education that students like and that they want to stay and continue. So our timeline, we've actually are now at the second stage. The first stage we passed. We did a financial plan for 10 years for the Regents in May, worked on the vision across the summer. Now, I'm happy to announce today that we really have sent in our application to be an accredited school. So that went in last week. It's exciting. It's the first step. Accreditation goes forever, but the first few steps are sometimes the hardest. So we're really happy that we are officially going to be listed on their website as an applicant school. I'm recruiting now for a senior associate dean or vice dean for education, and we'll be recruiting a couple other people across this next few months. But here comes the hard one. Between now and next August, we have to have the entire school planned. And that is a big job. And so I'm asking people in the community who are interested in helping on committees and things like that. We'll really start that in a major way in January, this self-study. But you have to plan all of the student activities, the student admissions, the student support services, the financial aid. You have to have the whole curriculum for the first 2 years outlined completely. And I think we're going to be fine on that one because we really have a way of using some problems that we can buy from another school that have been well used. So we certainly will do our own modifications, but that'll be the relatively easiest piece. But you have to have all the rest of the curriculum structure done. You have to have the faculty things done, all the committees set, all the faculty appointments set, and you have to have the affiliation agreements done, as well as the financial plan. But the financial plan, I think we're in good shape for. So that's a big job. We then go to what you send that into the LCME, which is the accrediting agency, Liaison Committee for Medical Education. They review it, and if they think it's good enough, they'll come for a site visit sometime over that year. And you hope at their meeting in May, they'll give you permission to recruit the first class in the fall of 2016. Medical school recruitment is really September to the end of December, so you have to have that a year ahead of time. And then if that all goes well, our first class will start in 2017, graduate the first class in 2011. So that's the plan. And as I said, the hard part is just starting now. One of the special programs we're thinking of, one of the special things we're thinking of doing is offering certificate programs, core blocks in each of these areas for everybody, but then offer a certificate program of 18 credits for medical students that want to get more in depth in any of these areas, but also for other health professionals who want it, or for continuing education for physicians and other nurses and others who want it, or for just people who really are interested in each of these areas. And each of them is an area that we think is really important. And we're just, I think, going to be adding a mental health one as well, because that's so important. And just figuring out the agencies and the way mental health is organized and understanding it better, I think it's going to be important for people to have more in-depth learning in those areas. But every student will get a core amount of material in these areas. So I want to talk about graduate medical education for a minute, because that is extraordinarily important and possibly the missing here just as much as the medical school is missing. In graduate, and just to review what happens, besides the college and university, 4 years of medical school, residencies at a minimum are 3 years. You graduate from medical school and you have an MD, but you can't practice at that point. You can't practice until you have finished your primary residency, which is anything from 3 to 7 years. And it's the surgery ones that are more like 7 years, but all of them are a minimum of 3. At that point, you can practice. If you want to, you can go ahead and take a fellowship, and there's varieties of fellowships offered. In Las Vegas right now, as primary residencies, there are 24 of them that the American Board of Medical Specialties certifies. We have 10, with 11 starting next summer. So 10 of 24 is all we train in all of Nevada right now. In fellowships, the American Board of Medical Specialties says there are more than 130 of them, but many of those are not certified. But just in internal medicine alone, the subspecialties would be things like pulmonary, GI, cardiology, rheumatology, kidney, and so on. There are 20 of those, and in this city right today, we train 1, and it started in July. There will be at least 2 more added next year, and this is added out of UNSUM. That'll be pulmonary and GI, and right now there's cardiology. So a huge gap in just regular specialties. So we need to add a lot more GME spots. We need more primary care doctors. That needs to be added, but we need to be adding these specialties. We need to be training our own. The physicians in this city want to be helping in training them, those doctors because they can then see how good they are. They can pick the ones that they want to hire. They don't have to be hiring everybody from the outside. So we need both primary care and specialty. The good thing about having GME is it brings faculty together. And in academic health centers, there's a team, and the team might be, you've probably seen it on TV if you haven't seen it in a teaching hospital. The team is the physician, faculty member, it's the resident, and it's the medical student. And they all learn from each other, but primarily the medical students learn from the residents who learn from the faculty. That team is what makes an academic health center work. So what are we going to be in 10 years? Fully accredited. I hope before that you can only get fully accredited by the time you have your class in the 4th year. That's when you hope that you actually get it, because those poor students would be in trouble if you haven't gotten it by that point. We will have graduated at a minimum 180 students. That's 3 years of 60, and I'm hoping if we have our medical education building sooner than that, it'll be even more. We'll have recruited, I'm sure, way more than 120 faculty. But we really hope we'll be increasing the physicians who stay in practice in Las Vegas. And you heard from Rob sort of the numbers, 5,300 new jobs at a minimum, and this is by 10 years. By 15 years, which were what his statistics were, it's up to 8,000 jobs. So this just keeps increasing and growing as we grow. 800 million impact at 10 years, 1.1 billion later on. The school itself should generate about $250 million, and that money comes one piece from the state, and I should say what we're asking for for the state for. In this next biennium, we're asking for $27 million. That would be $7 million for the first year, $20 million for the second year. By the time we cut out to 10 years, we'll be asking for something like $43 million a year, which sounds like a lot, and it is a lot, but the impact is that we would generate $4 for every $1 that the state would put in. The generation is first that state piece, then it's about $50 million of federal research money that would come in, and then it's about $80 million of clinical practice dollars that would come in from the physicians who are practicing as they teach. And then there's a piece of money that comes from the hospitals that pays for services for the faculty physicians. And then there's a piece of philanthropy, which we hope is very high as well. We are going to need a lot more money than the $43 million or in this early stage, the $27 million that would come from the state. We're going to need money for a building, first a medical education building, and then for a research building. So, but the payback is big, and the biggest payback of all, I think, is really that we should be a catalyst for better health care in this community and for expanding that economic sector. Thank you.
Do you have your agenda?
Thank you so much. That is so exciting that we actually have our papers filed. It's movement in the right direction, I believe. If now Regent Page and Chancellor Claich can come up, they're going to introduce our next speaker.
Good morning. We all know that keeping pace with Nevada's historical growth over the past 20 years has been a challenge. We also know these challenges will continue to compound as our population continues to grow and age in the coming 20 years and beyond. Unfortunately, the historical growth in the number of physicians in Nevada has not kept pace with our population growth, which has limited access to health care for people throughout our state. For instance, in 2014, American Medical Association report, Nevada ranked 47th in the number of physicians per 100,000, and in a 2013 report, Nevada ranked 46th in primary care physicians and pediatricians, and ranked 51st in the number of general surgeons and many types of surgical subspecialties. At the Nevada System of Higher Education, we believe we can play an important role in helping improve access to high-quality health care in Nevada throughout the expansion of Nevada's public medical education programs throughout the state. To that end, the regents, the chancellor, with the presidents, provosts, and medical deans from both UNR and UNLV have been working diligently over the past year to develop a coordinated and comprehensive plan for expanding public medical education throughout Nevada. Our plan deliberately includes both undergraduate and graduate medical education expansion because studies show 80% of students who complete medical school and graduate medical education stay in that state, whereas 56% of students who complete only graduate medical education in a state are likely to remain in that state. Lincy's foundation efforts in supporting this program will facilitate this forum today. Thank you very much. As we initiate planning for the new UNLV School of Medicine, we're thrilled to have a leader like Dr. Barbara Ackerson at the helm. And congratulations on that great announcement this morning. Her vision is ambitious and academically robust, with emphasis on urban, medically underserved and diverse populations, and a goal of improving access to high-quality care for our community. Dean Ackerson is working closely with Dean Schwenk and the UNLV Deans of Dental Medicine, Public Health, Nursing, and other health science leaders throughout NSHE to promote collaboration and excellence. She is also reaching out to our partners in the private medical schools and other healthcare stakeholders throughout our state as she develops her plan. As she begins to implement this plan, the faculty, students, residents, and fellows who will be associated with the new UNLV School of Medicine, that sounds pretty good, will engage in academic, clinical, research, and community service activities that will help promote improved access to high-quality health care before the new school even produces its first graduates for many and many years to come. The new UNLV School of Medicine will also be a tremendous boost to our economy with the estimated creation of more than 5,300 jobs, growing, as Rob said, up to 8,300, and a generation of economic impact of $800 million by 2025, when we saw the numbers up to $1.1 billion. As a graduate of UNLV and a longtime Nevadian, I believe this is a historic moment for UNLV, our community, and our state. By engaging in this discussion today, you can look back years from now and say you were part of history. Thank you again to the Lincy Foundation for facilitating this forum. We look forward to partnering with you all as we work to expand public medical education and promote the health and the people and the economy of Nevada. And now, Chancellor will have a few remarks. Thanks.
First, I'd like to thank Dr. Lang and the entire team at Lincy for inviting us to be a brief part of this. And I've assured Maria that the key word of that sentence is brief. It was really about not even a year ago that we all gathered here in this exact room and heard a presentation on the economic impacts of a medical school. And where I first met the speaker, I'm proud to introduce Mr. Paul Lumbach. Actually, I'm much prouder to know Julie and Angie, but I'm supposed to introduce Paul. And I'm supposed to read exactly what he's written for me. Paul is a national leader in medical education consulting. Over the past 25 years, he has completed more than 2,000 consulting assignments. I think that's about 5 a day. And he has done that in all regions of the United States and, in fact, globally. He's participated in a leadership role in the either development or expansion of 25 medical schools over the past 10 years. And I'm proud to say, as the lead consultant for the Nevada System of Higher Education, in the expansion of medical education from a system-wide standpoint. I'd also, again, like to thank the Lincy Institute, who introduced Paul to us. You brought him here, and it was clear to us that two things were readily apparent. Number one, we could see expertise of Paul and his fantastic team. And truly, Angie Lockwood and Julie Schmiel are part of a three-legged stool with Paul that does wonderful, wonderful things. But more importantly, I think, as the chair emphasized in his remarks, it was clear that there was going to be the need in something of this complexity for some independent assistance. I am just a retread lawyer, and for me to understand the complexities of this area of higher education would be virtually impossible without the assistance of someone as talented as Paul. So here we are a year later, a year away from an economic impact report, and we're listening to Barbara Atkinson announce that we're proceeding with the LCME. I think that when we were here last November, there was some concern expressed by a number of us of how serious we were and where the spirit was. I couldn't be happier to be following Barbara in that announcement, which I think indicates where we are, as the chairman indicated, and introducing my good friend, Paul Umbach, who will talk about a healthier Nevada and some of the aspects of medical education.
Thank you, Dan. Appreciate it. Good morning, everybody. It is a real pleasure to be here. I want to thank everybody from UNLV, the Lincy Institute. Thank you, Dan, and also Chairman Page. We have a lot to cover today. I want to first say that to do this requires a vision, and then that vision requires a whole lot of commitment. But once you get past vision and commitment, you're right around the corner from action. And I feel that when I look at the leadership that so many of you have taken on at the public side, at the private side, and the amount of opportunity that we have in front of us, I would say that at this point we're not talking about it happening, it is happening. And when you look over the last year, we went from a lot of different studies and we moved into, and I was going to echo what Dan just said, to look at Barbara being here and also other guests that are here to talk about this program. So I'm going to get moving right away. There's been way too much talk about Trip Umbach. I do want to recognize my colleagues who have been working day to day here on that project, Angie and Julie, who a lot of you know. And I'm not going to spend very much time on the assignment. It's an exciting assignment. One note I want to make, though, is that it's kind of innovative here, and I think the time is right here in Nevada because all of the change that's going on in healthcare, in education, in medical education, all the change that's going on in our society, our demographics, I always think change makes a great environment for good planning. And we have this opportunity now, within the midst of all this change, to put this program in place. And NCHI's leadership of this program is far-reaching in that it's not just, and I'm looking at some of the regions that are here that have been so part of this, it's not just to help the educational program at one of the schools, it's really at all of the schools. It's not just to create medical education for an MD degree to be granted at another school in the state. It's actually to do the entire continuum of planning. And that's my role today, is to really give you a picture into what's all involved in our study. So we start with an overview of medical education. I want to thank Angie for finding this. In the colonial period and right after the colonial period, it really wasn't hard to become a doctor. If you look at the screen, you'll see some of the requirements for being a doctor. And we would call this phase 1 medical education. Now, your outcome had to be really good or you couldn't stay in business as a doctor. Being a doctor in the old days meant that it was a cash business. And I guess that you were evaluated on how good of a doctor you were, because if you didn't have good outcomes, no one would pay you money. But obviously becoming involved as a doctor, as you can read, wasn't that strenuous. I removed from my notes any comments about who might have still been alive here and had this kind of training before. So I'm not going to say that there's some doctors that remember this. The Flexner report came out in the early 1900s. It's not on the slide, but I'll tell you that by the early 1900s, there became another phase of medical education, and that is really formalizing it. And I think the obsession there was it was very disease-focused. So from the early 1900s to about today, we have what I call phase 2, which was very disease-focused. And there was a lot of medical schools, most of the ones we have today, that were developed in that era. We're in phase 3 right now. Phase 3 began with a few really important reports. Some I might reference in the speech, but you can just go online and look at what's happening with medical education. And now the obsession is not that different, really, than in the colonial period, and that is population health, keeping people healthier. That's the only way you survived medicine in the old days, was taking responsibility for your care, becoming really, really focused on making sure you didn't have disease and making really sure that you were very careful about how you really presented yourself as a human being and how you then at that point receive care. So I think now what I'm going to call eternal health is the next phase, not fixing sickness. And those doctors that we're training now at these schools, and I'm looking at my new friend from the university in Orlando, they need to really be focused on eternal health, not just how can we fix all these diseases. I think Barbara did a really nice job. I'm going to go through some of these slides pretty quickly of saying that there are many parts of medical education. It's an entire continuum. And one thing about this continuum of medical education is that it takes a long, long, long time. And as you can see, Barbara had a similar slide, we're looking at a very long process. So when I use the word commitment at the beginning of the speech, what I was really saying is long-term commitment. And there's some innovations going on. We have a couple projects around the country, one in Northern Virginia, one at the University of Illinois, where we're looking at maybe shaving off a year or two for certain students. There's some innovation now that's allowing very, very highly qualified seniors in college to start taking classes that count toward medical school. There's some work being done on a 3-year curriculum in some places. This is all changing a little bit, but the reality is for the average student, it's a long commitment, and it's a long commitment for communities, both public and private players, to support this education. And another thing that was mentioned before, but I'll say it again, if we don't focus at the K through 12 and at the undergraduate and community college level, we're not going to have qualified folks from our state that will be able to matriculate into the medical schools. And then at that point, if we don't have the graduate medical education, we won't have very much of a chance to keep them in our state. So this continuum is exceptionally important. Medical education, unlike geography education that I took, my graduate degrees are in geography. I'm an economic geographer, one of about 400 in the whole country. We only had to go to class and then go on cool trips everywhere. I loved my geography graduate program. And then by the doctoral level, all you did was write geography theory papers and do more trips. We never had to see a patient. We never had to touch anybody. So at the end of the day, if you look at medical education, there's educational activities. There's also patient care activities. Doctors, as you know, are trained both in classrooms, clinics, hospitals, they're trained in community settings, and when it's all said and done, they have to be experts at keeping the care of patients as the part of their training. And as you can see from this diagram, it's complicated. It involves an entire community. And you know what I also learned as a patient in the last several years? It also requires patience. We're part of the educational process. When we're in a setting where a medical student or a resident is there, we're all part of it too. So it's probably the most holistic training of any discipline in the entire academic world. Graduate medical education, I'm going to deep dive a little bit here. I think what a lot of people don't understand, Barbara said it first, those folks that graduate at that white coat ceremony that get that MD degree, or in an osteopathic school, the DO, they are actually not able in this country or in this state to practice medicine. So they have to have this additional training. And the sponsorship of these programs can be public entities and medical schools. They could be hospitals, consortiums. There's a whole bunch of ways. The VA has a big training program. There's also federally qualified health centers. There's a new program called Teaching Health Centers. But no matter what pathway you go through, and here are some of the pathways you can go through, we have to create in our state more training opportunities. Right now there's about 350 residents in these 10 programs in the state. Barbara was mentioning some of the numbers, and we need to have that grow by several hundred more as this new second medical school, public medical school, gets added to the state. So it's going to be a lot of these pieces coming together. Some residents are going to be developed through hospital programs. Many are going to be sponsored programs through either UNSUM or the new medical school here at UNLV. And there'll be all kinds of other pathways to follow, like teaching health centers and FQHCs. Federally qualified health centers actually have different funding streams. The VA is also an organization that's upping its commitment to graduate medical education. This slide here just talks a little bit about the prong of federally qualified health centers. There's a lot of reasons to collaborate now with the public health world. And we're seeing in the last maybe 5-10 years a real shift from doctors being trained in isolation and from the rest of the health professions being trained in isolation. And now we're looking at really bringing together and marrying teams of caregivers in settings like community health centers. And the Affordable Care Act had a big kind of push toward that. But I think a bigger push toward that is just the realization that the outcomes have not been as well without this new team-based program. And doing it in community settings close to where people in need are just makes a lot of sense. The other thing that's happening around the country, and my team's been involved with about 20 projects now, is bringing groups of hospitals that have never had residency programs together. Something that the federal government has never wanted to tell people since 1965, and especially since the Balanced Budget Act of 1996, is that if you've never had a residency program, you can actually start one and establish a federal funding stream. And I have clients almost every day who call me up and debate this with me because they're sure that I'm wrong on this. They're saying there's no way that you could be right that a hospital, my hospital, could establish federal funding for graduate medical education. And I always say, we're right, it's just not promoted. And so one of the things we're doing around the country is getting groups of hospitals together who have never started a residency program and encouraging them to receive some of the federal funding that they can receive. And doing it as a consortium, doing it as a group of hospitals around a region or a state is a very effective way to do it. GME funding, as you might know, and if you don't, I'm going to tell you all about it, comes largely from Medicare and Medicaid. And one thing about this program is that in the mid-1960s, it was determined that resident training would be paid for through Medicare. And there's a formula that was developed to allow the amount of money that you would receive as a hospital to be proportionate to the number of people on Medicare that you were serving. And as a result of this program, and it was based on the ratio of beds, there's a very complicated formula. But as I just said before, in 1996, if you had a program as of 1996, let's say you had an internal medicine program in Iowa, or you had a surgery program in Kentucky, or you were a big academic medical center like UCLA that might have had 40 or 50 different programs, at that stage, at that point, you couldn't get any more federal funding. Now, here's another misnomer. Did the cap mean you couldn't add more residencies? No. Did the cap mean you couldn't have more residents? Not at all. In fact, about 1 out of every 5 residents in America are funded by something other than CMS. And in fact, any hospital that wants to, any teaching hospital that wants to add a program or add more residents can, but the federal government won't pay for it. So it's really a cap on funding, not a cap on numbers. And again, a lot of audiences, a lot of people I talk to say, I'd love to add more residents, and they think they can't because they don't think they can do it. But yes, you can. You just have to pay for it. So that's where a whole bunch of innovative funding programs have come together to make it possible, even in places like University here and some of the other hospitals in the region that have programs to be able to grow their residencies even if they have a cap. The current funding situation is not good from the public side. If you look at federal funding, it has been declining. I think one thing that's very important to keep in mind is that there's not a big groundswell of support in the United States in the current situation to add more funding. There's about $11 billion a year that's provided by Medicare. There's a lot of pressure right now in Congress to grow graduate medical education, to fund it more. And yet, with all that pressure, because there's a need for doctors, there's probably a need between 80,000 doctors and 120,000 doctors, depending on what study you look at. For all of that pressure, and for the fact that we've added 30% more medical students, we still don't have any movement. And one of the reasons why we don't have movement is that there's a lot of kind of change and uncertainty right now in the funding. And part of it is that the economy kind of got bad at just the time that healthcare reform was changing, at just the time that states were dropping out of putting Medicaid funding into GME. Traditionally, if you go back about 20 years ago, about 20% of all residency training in America was funded by Medicaid, and that was a pass-through from states. Nevada, like many states, dropped out of providing this funding, and it was because there was so much pressure on the Medicaid system at the time, and it was seen that we can't give Medicaid funds for graduate medical education. And then private insurers were supporting medical education a little bit, but now the private insurers are saying, we're in a situation where it really doesn't work for us to be sponsoring graduate medical education. So let's count them. We have states dropping out. We have the federal government freezing and not adding more. We have the private insurance sector not sure about what healthcare reform is going to look for them. We have hospitals that were major players, the major player, thinking that all of their surpluses that they had in the old days are going to be turned to deficits. So they're in a situation saying, I don't know about how we're going to continue to fund this. So the solution through all of this is actually a couple of reports that have come out. One of the reports that came out recently with the Institute of Medicine said, well, maybe what we really need to do is focus our spending on graduate medical education and focus it on very specific regions, certain programs, certain populations. And I think this kind of thinking and actually having a GME transformation fund is good news for Nevada. And it's good news for Nevada because if this and other reports that are recommending this kind of guide Congress in the next 3 to 5 years, we're going to see underrepresented states like Nevada finally have pathways to receive better federal funding. I don't know if you know this, but I'll tell you, about 1 out of every 4 residents in America are in 5 Northeast states. New York, Pennsylvania, New Jersey, Massachusetts, and Connecticut have about 1 out of every 4 residents are in those states. If you look historically around the country, most of the southern and western states are underrepresented in the amount of residents per capita they should have. And I think that these kind of movements, and there are many other reports that we will cite in our final report, that are kind of moving in that area. I think one of the things that we have to keep in mind is that graduate medical education and undergraduate medical education have to be seen as a package deal. And the reason why they have to be seen as this is that there's so much more benefit to training the undergraduates, the MD students, who then complete a residency, and there's a whole bunch of benefits to healthcare when that happens. Benefits to hospitals, benefits to community health, and I think if you look at this screen, you'll see that there's lots and lots of benefits, also economic benefits from hospitals having teaching programs. I think the key to this whole program, though, is making a difference in the community. We have a huge challenge in Nevada to keep this growing and ever diverse and challenging population healthy. We look at Rob's numbers before. I can't believe that the coefficient for health is at 0.62 2 or 4, when you consider that that really means that billions and billions of dollars are leaving the state every year. So the old line that the largest health system is McCarran International Airport starts to really hit home when you realize that so many people with the means to travel do travel. But I think the bigger question is, what about those who don't have the means to travel? And what about the health needs of this very diverse population? So we really think that there's an economic benefit to having this healthcare sector grow. And I believe that academic medicine has been the most proven strategy to do that. And I think when you hear from our other speaker today, and certainly the first speech, you'll see that there's really quite a strong vision for that. I want to also say that, that through the expansion of GME and UME, we're able to really start to develop a pipeline that will lead to success. Two things I want to kind of leave you with in terms of the success of this. And it started with the cover slide, which I didn't comment on, a healthier Nevada. We don't usually think about it, but if we don't have folks trained to help us as people in this audience become and maintain our health, that's really a deficit. And I feel that this program, when it puts together the undergraduate and the graduate medical education and the continuing medical education, we have a great opportunity to see the health status improve. But we also have the best opportunity of working through the public system. We have the Board of Regents has made a strong commitment to have a program that's not just undergraduate medical education, but also graduate medical education. And through this plan and through this partnership, we're going to achieve a lot of wonderful things. So I want to thank you for your attention and time this morning. Thank you, Maria, for inviting me. We're going to do Q&A, and we're going to do Q&A, and Rob and Barbara and I can all respond to questions. And if you want Chancellor Klaich to respond or Chairman Page to respond, I can speak for all 5 of us. We're ready to go. Who wants to go first? Yeah, yes.
Where will the medical facilities be built? Here on campus or in another area?
Well, we're still in the process of deciding that. One of the logical places is in the health district by UMC. The county has offered the plot of about 10 acres where the old health district hospital building was. It needs to be imploded and go away. But that's right beside our Shadow Lane campus, and it's right across from Valley Hospital. And that's one spot. North Las Vegas has offered space. Across from the VA, they're hoping to have to actually get 130 acres right across the street from the VA. 130 acres is a lot better than 10 acres, but it's a long ways from where the rest of the center of activity is. In Henderson, St. Rose system has some land as well, so that's another possibility. So we're still in the process of determining that for sure.
There'll be 2 buildings eventually, is that right?
I think there'll be 5 buildings there in a reasonable time. The first one would be the medical education building. That's clearly our most important. Then there are really 2 research buildings we need. We may build one first, but we need a basic research building for laboratory work, and we need a translational research building. And that's more office type stuff and computer kind of things and person activity, population-based things, public health things. We absolutely want the nursing and allied health building to be there and to come up almost exactly at the same time as the School of Medicine, because we really want the students to learn as teams. So we want them to share the same library facilities, share recreational facilities, and actually share classroom space together. So that building is absolutely essential. And our School of Community and Public Health wants to be there too, so that's 5. And so we're looking right now at how we would design the site, including pieces that are Shadow Lane and pieces that are UMC, maybe with a parking garage using some of the flat street parking. So.
Does it all have to be in one place, or could you spread it out?
Well, I think we are probably going to ultimately put pieces everywhere. I think we really are going to need a building by the VA. We really want a very close partnership with the VA. We're working with them trying to actually start there, because if we started a building tomorrow, it wouldn't probably be ready by our first class in 2017. So we're working with them on leasing space, but we know we want faculty that jointly does research with them. We know we want clinical programs jointly with them. So there'll be something there in North Las Vegas regardless, and something in Henderson for sure as well. But we're really thinking about where the best site for the overall piece is.
Yeah. Other question? Yes. Somebody else? Over here. Hi.
Yeah, actually this might be for you, Paul.
Yeah.
Right now we have, obviously, the UNLV Med School, which eventually 120, 180. We have Truro currently in town, and then Roseman coming on. Are we seeing capacity, or are we just getting up to where we need to be?
You're actually, with all of the plans, getting to a little bit below where you need to be, but you're getting there. And we feel that there's opportunity down the road to even grow the class sizes, especially here in Southern Nevada. Capacity is interesting in that once you get to capacity, you become a magnet for other states. And one thing I like about Nevada is that it's right in the middle of about 100 million people in what I'm calling the Mountain West and California. So over time, if you did grow even a little more, you'd be able to attract folks from other neighboring states that are also way below their number.
Yeah, and I'll add to that. So yeah, 0.64 is way low. You look at Kansas City, which it was 100,000 people bigger. Mm-hmm. And you look at the numbers out of Kansas City. Most big regions export this stuff.
Right.
So even Tucson exports to Mexico, and it exports to all of southern Arizona. We're in a sort of greater Mojave region, where southwest Utah is booming, for example. And so there's a larger space out there of people who are proximate to us, who would use us if we built that capacity. So we shouldn't be at 1.0. If you look at the median for all the regions above 2 mil, they're mostly export. Some are strong export. Some of the Texas cities are strong export. Southeast Texas in particular is a strong export. But even sort of a Kansas City is taking up a lot of the sort of Great Plains, a lot of the sort of farm belt, if you will. Mm-hmm. And so we have an opportunity to build out our regional demand, then export locally, and then finally, we're a center of tourism.
Right.
And so we can still offer that. Right now, we're the world's leading medical tourists. We're the medical tourists. It's all of us. We go to California for health services. We could reverse that flow, and the wealth that would accumulate from that is substantial.
Yeah. So,
let me just say for Kansas City, all the students that are there being trained and have been, Kansas is still very low. It's, I think, 17 or 18 from the bottom in terms of number of doctors per population. So it's not as if even training that many, we've been able to really get up to capacity there. So there's a huge need in this country, and Las Vegas is the worst of the need.
Yeah. Time for one more question. Yes. Hi.
Doctor, could you speak a little bit to the faculty? You mentioned 120 faculty. Relate that to time, and how's that allocated amongst education or teaching, research, and a clinical faculty out in the community organization? Right.
Well, that is predominantly the piece that would come from the state budget part. And so those are the ones that I would see as teachers. And what we plotted was that we'll have some administrative people and some pure teachers. We'll have a lot of faculty who are half and half. They'll either be half teaching and half research, or they'll be half clinical and half teaching. So that's what that 120 pool is. With building programs that we hope philanthropy will help us jumpstart many of those programs, we could end up in 10 years with a faculty that's 300 or 400, and I think it would not be unreasonable. And I think you'll hear what's happened in Orlando in that regard. So this is the pool that's at least half teaching and half other.
Great. Lindy?
I don't know if this is working. I feel like 10 years ago, this was common sense. 2 years ago, we were starting to get data. Now the story is so compelling and obvious. What are our barriers? It doesn't matter how compelling or how obvious this is. What are the barriers that we're going to run into as a southern part of this state to get our med school done? Besides money. We already know money, yes, of course. But what are the other barriers?
Actually, I think money is probably the only barrier that I see to the whole thing. I see strong support from the physicians. I found strong support from the hospitals and the systems. From the university itself, huge support. And that surprised me because sometimes there's a competition between a medical school and a university. And here, because it's helpful for Tier 1, I don't see it. But this is going to take not just the state dollars, which are a challenge just because of where to find the dollars. I think people have a will to give them if they could find them, but are having trouble finding them. And it's going to take huge philanthropy. I can't stress that more. We're looking now for a naming opportunity for the school, and we're looking for people to donate for the buildings, and then for building programs one at a time. You know, a breast cancer program that can do things that aren't being done now in terms of research. The liver transplant program, those kinds of things. So I have to say, I think that's it, money.
Yeah. One thing I want to say is that the public sponsorship through NSHE has been a real step forward. The statewide steering committee that we are the consultants for have gone a long way, not just with historic MOUs and vision statements, but really a budgeting process that looked at raising the money for quality medical education, both here and also in Northern Nevada. And one other thing that might not be known to the group, and that is the commitment of the state to really not just talk about it, but actually to make it happen is a really, really big step forward. So I would say that's been important.
One follow-up then. So money. So we go up to a legislative session. They're going to say no unless we bring a pot of gold. So how big is that pot of gold?
Well, the part that we've asked for is about $27 million in this biennium. UNSUM from Reno has to do a lot of growing too. And so between their GME dollars and their own growth that needs to happen, they've requested another about 26 or 27 million too. So the pot that's being asked for this year is something like 45. I could add those up, I guess. But
50 something.
Yeah. So that's the pot. And I should just say that UNSUM, in my mind, has almost a harder job than we have in Las Vegas. They need to build residency programs in their hospital in Reno. They need to think about how to work throughout the state, and they need to build faculty in order to do that too. So it's a critical issue for them, and we need them to be building residency programs here as well. So there's a lot to be done on both halves of this.
All due respect, they've had 30 years to figure that out.
Yeah.
I feel nothing about that. I just feel like they've had plenty of time to build capacity. If they've chosen not to, then so be it. But we have a bigger problem down here.
I'd like to also address, let's move from barriers to opportunities. And we've got just 2 minutes left and we go to break. So this wraps it up. We have a biotech sector that looks like Flagstaff's. Okay, now I don't know, I checked, turns out we got more people than Flagstaff. Just throwing it out there. So whatever city gets this, so we're talking the state has to do this and philanthropy has to do this. Whatever municipality or county winds up with this asset wins, because assets like this accumulate private firms in the tech sector that are biotech-driven firms, computer firms, bioinformatics. And this region, despite the fact that tourism has brought us to the dance and shall always lead in our lifetimes, and is actually thriving, and that's very fortunate because it covers so many of these sins. Thank you, tourism. That underneath that tourism core, to the extent that we could just get a biotech sector that's for a city of 1 million people, not 2 million, just more than 250,000. That's all positive. We don't have to be San Diego in biotech. We could just be Tucson in biotech, and it would help. And whatever municipality gets that should put skin in the game, because they have bonding. They have sources of revenue within that city for economic development. And so there is also a local contribution to this. And this is the richest part of the state. This is the area of the state that has the highest capacity to contribute. So don't undersell that. So there's three big components of this. Philanthropy, yes. State share, which is really basically the operating. A lot of the building construction should come from the municipality, and then there's new market tax credits from the federal government, another thing that we didn't even have one credit till this year. The program began in 2000, and the whole time from 2000 till today, we had zero new market tax credit money in Nevada, in southern Nevada. We finally have that. You cannot believe how many places around the country have leveraged that for the med school. So there's so many sources of fundings for this thing, and we have such a large region to leverage off of that this is now in our hands. As long as the state, and it's in the state economic development plan, says, yes, this looks like a good idea, and here's a nominal amount of money to secure operating. The rest of it's up to us. I think we'll get it done. I have all confidence we will.
One other stronghold is the idea of developing a strong network of federally qualified healthcare centers. In the majority of, especially if you go back to the East Coast and the Midwest, they have very dense, these centers not only provide care on a sliding scale, so for those who don't have access, even with the Affordable Care Act, now they're becoming teaching grounds for the GMEs, as Paul referred to. So there's also a huge opportunity, and they're funded, they get paid at a different rate from Medicare and Medicaid at a higher rate, because they're providing those who don't have access. So because of that, that's another opportunity to really expand, and that can draw money in that can ultimately help build both the med school and our GME programs. But with that, we're going to go to break, and we'll start back around in about 15 minutes.